Good evening, everyone. Welcome to another exciting Vestibular First Journal Club. We have with us, of course, another very special guest, Dr. Jonathan Chung, and we're going to let him introduce himself a little further before we jump into our topic tonight.
Hey guys, I'm Jonathan Chung. I am a chiropractor and I have a focus in neurology. So I have a board certification in chiropractic neurology. I'm also a fellow in the American Board of Brain Injury and Rehabilitation. I do some teaching with a postgraduate education course called the Carrick Institute. And yeah, I have a passion for treating TBI, vestibular disorders, autonomic disorders. Yeah, on top of a lot of my normal chiropractic caseload too.
He's not busy at all. Um, so, tonight we're going to be discussing manual therapy for cervicogenic dizziness. So, the article that I pulled for this topic, and there's a few related articles we'll touch on, but this is kind of the main one, is this comparison of Mulligan sustained natural apophyseal glides, I can say this, and Maitland mobilizations for treatment of cervicogenic dizziness, a randomized controlled trial. So, they're taking these different manual therapies, comparing them. We're going to get into that a little bit more here. So, of course, I have to start everybody on the same page. It's my favorite thing to do because we have all comers that listen to this journal club. We have people of various levels of experience. So, first, we'll talk about the vestibular system. That's our favorite thing. It's the inner ear balance sensor. It lives near our hearing structures, and it's very deep in the inner ear. This structure is connected to the brain because it has to send information. We have one on the left and one on the right sending information to the brain about where we are in space, what's going on, whether we're moving or still, that kind of thing. And then, of course, there are various structures in the brain that connect together with the eyes, with the sensors in our joints, all this different information that comes in and gets organized and integrated by the brain when everything is working well. Now, the neck is also a piece of that, right? So, in the neck, we have sensors in our little joints in our vertebrae and sensors in the muscle spindles, and all that information comes from the neck, essentially. That's supposed to tell us kind of where we are, where the neck is it positioned, with my head tilted or straight, all that sort of thing. If that information is not accurate, so this could be possibly due to postural issues, damage from trauma, say whiplash, that kind of thing, car accidents, concussion, an injury of some kind, trauma, falls. Likely will have some resultant abnormal range of motion and possible changes in vertebrobasilar blood flow. So this is not a happy neck, as I like to say. And if the neck is not happy for some reasons, it might not know where it is as much. So the impaired proprioception. And when the information from our eyes and our vestibular system and the neck all come together, and they don't agree because the neck is maybe not knowing where it is as well as it should. It's saying something different than the vestibular system in the eyes. This conflict, in theory, could result in a sense of dizziness. Now, we're not going to get deep in the language here, but let's just say that people use all kinds of words: floaty, off, fuzzy, weird, not right, off balance. And they could use those words, and there could be something wrong with their brain, like a tumor. There could be something wrong with their inner ear, like little crystals that we all have that go in the wrong area of the inner ear sensor. So, unfortunately, the language is not always the way that we for sure know what's wrong. However, it is common when cervicogenic dizziness is at play that instead of a spinning feeling, the room's moving, I'm moving, most likely instead the description will be this kind of I don't know where I am in space, an altered orientation in space, a sense of disequilibrium due to this abnormal kind of sensory input information from the neck. And that's kind of what tends to get described. Now I'm going to let Dr. Chung hop in here and just kind of add anything to that piece that just kind of, when patients come in and they describe what might kind of possibly make you suspect cervicogenic dizziness?
Yeah, so that's one of the things where going through and really getting to the bottom of what a patient means when they describe themselves as being dizzy, because patients really they don't know where the terminology comes from, and oftentimes other healthcare providers may have directed them in the wrong direct way. So we'll have patients that will go to their primary care doctor and tell them their symptoms, and then the primary care doctor may automatically just jump to telling the patient that they have vertigo when they don't necessarily have vertigo. So when I sit with a patient, I'll ask them, it's like, well, when you say vertigo, what does that actually feel like? Can you tell me what that means to you? And they said, well, it doesn't feel like I'm spinning. So that's usually the first thing that I'll checkbox on there, and they say, all right, they're not spinning. And they'll say, like, I just feel like I'm kind of off. It feels like if I take too many steps, I won't be able to catch my balance that well. I just feel like I'm kind of moving around, I'm swaying, and I just can't find my center spot. And those are the things that will cue me into a likelihood of some type of cervicogenic dizziness. And then I'll follow that up with things like, do you have any neck pain? Do you have any
Mm-hmm.
headache issues? Do you feel like you can't turn your head in one way or the other? Or something as simple as, did some of these symptoms come after you hit your head? Or did some of
Mm,
these symptoms come after you were in an accident of some sort, even if you don't have pain with that? So those are some of the key things that I'll look for in my history for these types of patients.
perfect. Yes, I agree. So kind of an association, possibly with an event, versus a gradual onset. And, in contrast, let's say they came in and they said, oh, yeah, I feel off. And about 4 weeks ago, I was throwing up, spinning, whatever. Well, that starts to sound to me like either an inflammation and some sort of vestibular neuritis event, right? We call that a vestibular crisis. Or it could be a similar issue, but Meniere's, which is an intermittent swelling of the inner ear. If they have some hearing changes or loss, we might suspect that possibly. Or maybe vestibular migraine, although that has its own kind of associated symptoms, which we'll get to shortly. So it's good. You're being a good listener, and on the flip side, again, we should always acknowledge that even the most wonderful patient may not really, like, they'll fail to mention something. I'm sure you've had this happen. Oh,
Mhm.
yeah, I guess I did fall down last week and hit my head. Like, it'll come up like 3 sessions later. I'm like, okay, really? So, this whole getting a history thing is trickier than one might think. Let's talk about the Baronet Society. So, the Baronet Society is a group of clinicians of various disciplines who come together as they're able to kind of gather information, present research, and really make statements at times about different vestibular conditions. And they have developed and recently published a position on cervical dizziness. So I really like this picture. This is awkward.
Mhm.
So they basically said, well, what we know to be true if you've actually dug into the literature yourself, which is that the evidence to support cervicogenic dizziness as a condition, which I just described the theoretical definition, is lacking because we don't have enough. It doesn't mean that it's not a piece of some patient's puzzle, in my opinion, but it's just not as easy as doing a scan and finding a lesion from a stroke or a tumor where you can see it on the structural issue. Okay, that seems to be the root cause of your symptoms, right? This is not that way. And I think just it'll be good to see what comes out of literature in the next 5, 10, 20, 30 years, but who wants to wait that long, right? So I'm going to give you what we have today and
Mhm.
we'll go from there. One thing that the Baronet Society emphasized, and I agree with completely, is that migraine, including vestibular migraine, is by far the commonest cause for the combination of neck pain and vestibular symptoms. So we're going to go through the vestibular migraine criteria briefly for those who are not familiar. Basically, these are multiple episodes of dizziness type symptoms or off balance, might be a variety of descriptors in my experience. Usually it's moderate to severe intensity, can last, honestly, even little mini spells can be a few seconds, but usually they're a few minutes, up to 3 days. The big things that make migraines stand out to me as a suspect. I like a detective. I like to think of myself as a detective a little bit, you know, with these complex dizziness situations. Headache with certain qualities, one-sided, pulsating, aggravated by physical activity, moderate or severe intensity, history of migraine. I used to get a bunch of headaches, and now that I'm in my 50s, they kind of went away, but now I just get these dizzy spells all the time. It's like, okay, this sounds like maybe your migraine shifted, which we know can happen, particularly in postmenopausal women. Photophobia or sensitivity to light, and phonophobia or sensitivity to sound. Now, this is a tricky one because a lot of people, when they don't feel good, maybe they don't want that sensory input. So, we don't want to lead the witness, as I like to say.
Mhm.
But, we can start to hear people who are like, oh my gosh, I just feel like I have to turn off the lights. I need to make it dark. I need it to be quiet. It's just, I can't even handle even the smallest sound. Okay, well, that starts to sound a little bit more, like familiar migraine territory to me. And then something they call a visual aura, this kind of like weird thing that happens in my vision that makes me think I'm going crazy because I don't know that that's what an aura is at first. It'll get like wavy lines or, electric looking things or, starbursts. There's all kinds of different descriptors I've heard for how people's visual aura. And it just means the brain is cranky and things are firing in ways that can make us experience sensory information in an atypical and not necessarily a very pleasant way, is how I kind of summarize migraine. And then there's this probable vestibular migraine, which is not as strict of a criteria, but still kind of has a lot of these same features. So it seems to be that cervicogenic dizziness should not fit the vestibular migraine criteria, if that's what you're going to call it. Now, we can dig into how conditions can coexist later, but for now, if we're just kind of saying A or B, that's something to consider. And then dizziness triggered by neck turning. So if the patient's like, yeah, every time I go this way, that's when I really feel off, that's usually not the case with vestibular migraine in general. And also with vestibular migraine, typically you can't fully treat it just by treating the neck. There's usually some sort of, what are their triggers? Is it hormonal? Is it, lack of sleep? Other things that maybe kind of are factors. What do you want to add to this, Dr. Chung?
I think a big differentiator for me is when people have like the classical type of a migraine, the headache phase will go through different phases. Like you have the prodrome phases, you have the actual headache phase, and you have like the aura phases. So if you see that someone's vestibular symptoms are kind of coming in these waves, I think that makes it much more likely to kind of associate with a migraine as well, because there are some patients with vestibular migraine that don't actually get the headache portion. So
Right.
being able to identify if they're kind of going through this
Pattern.
slope pattern, then I think that makes it much more likely to be migraine associated. And then I will definitely refer those patients to get a headache neurologist type of evaluation or something along those lines.
For sure. For sure. Yeah. And I think with that, the idea that a patient might say something like, I can feel like it's coming or I can tell it's going to start. That is usually a tip off to me most of the time.
Definitely.
Yeah.
Definitely.
All right. Ooh, we have some other journal clubs on vestibular migraine, don't you worry. So if you're free to go watch the one that we did it's over a year ago now, I think, with Shinbei, it was lovely. And we have another one coming up on vestibular and auditory manifestations of migraine later this year. So very excited about that with Dr. Jeffrey Sharon. So anyway, migraine's a big topic. All right, moving forward. So another comment the Baronet Society made is that, since head movement aggravates symptoms in almost any vestibular condition, the common finding of increased neck muscle tension in vestibular patients can be kind of a chicken and egg scenario. Well, they didn't say that, but that's what I say, right? So did the person have, let's say, BPPV, and then they stopped moving their head because they didn't want to feel, some spinning when they, turn their head. So they're, I'll just turn my body and then maybe I won't feel that sensation, right? And so they kind of has secondary, what we'll call neck problems, right? They're kind of stiff, joint issues, posture issues, you name it. Whereas somebody else might have neck problems that lead to some sort of dizziness, the cervicogenic dizziness. So it's a tough thing to kind of parse out, right?
For sure, for sure. But I think that's where some of our torsion testing can help out, at least facilitate some directionality with that.
Agreed. We're going to dig into that shortly. And then, of course, we must not leave out possible vasovagal, cardioinhibitory, autonomic, dysautonomic issues, that lovely laundry list, presyncopal, all this kind of blood flow, cardiovascular stuff that also can make people feel off, fuzzy, funny, disoriented, off balance, lightheaded, like I'm going to pass out, fill in the blank, right?
Yeah, 100%, 100%. So like, especially with how many people are starting to figure out that they have POTS now, like that's definitely on the radar for a lot of people now.
For sure, for sure. So, speaking of, we have a brief slide on that. Now, I pulled this from our non-vestibular dizziness lecture or journal club, excuse me, that we had with Dr. Gold and Dr. Steenerson. I always say her name wrong, but she's lovely. So this is a slide about blood pressure, heart rate, things we should be checking, and things that we could check to an extent as physical therapists at least, or in the chiropractic world as well, and where we might need to refer for like a full tilt table test that's a little more involved, to try to identify officially, does this person have orthostatic hypotension? Do they have postural orthostatic tachycardic syndrome, which is POTS? So just anything you want to add about dysautonomia. This is not a lecture on dysautonomia, so we can't get too deep, but just kind of a key feature or how you might differentiate or kind of pull that out from cervicogenic dizziness and kind of look at those separately.
So I'll do some orthostatic blood pressure testing in my office. So you might just get them going from laying down to standing and take their blood pressure and pulse within that minute time frame, and they'll show some signs of that during the testing. Also, another bedside test is the 10-minute lean test, where you just have the patient like step forward, lean against the wall, and hold that position for 10 minutes. And a lot of these patients will become symptomatic. You may even see some like discoloration in their hands during that time phase. And that's another sign that they're dealing with an autonomic problem that should be further evaluated, as opposed to something a little bit less imminent, like cervicogenic dizziness.
Right. And they don't have to move their neck to feel these symptoms with dysautonomia, whereas typically cervicogenic dizziness, there's got to be head neck movement. That's probably a good additional consideration, right?
Correct.
Perfect. All right. Like I said, that could be a whole talk, but not today. All right. So on to more differential diagnosis before we get into our treatment part where we talk about the article real quick here. So absolutely, at a minimum, you need to screen the vestibular system. You need to, do a neuro screen, and you need to see if there's any cardiovascular hints that you might need to dig into. So vestibular exam, again, we are not making a full lecture on this, but suffice to say that if you don't have vestibular training and you want to be good at it, there's plenty of excellent courses. So go find one. Where Dr. Chung Cheese is at Carrick has lots of them, but there's lots of other offerings out there, certainly in the physical therapy world. There's plenty of great choices. So suffice to say, you should know these tests and do these tests amongst others when you want to kind of screen that vestibular system. Because if you say it's cervicogenic dizziness and the whole time it was BBBV, come on now, let's take care of that. Because as we were talking about before we came on here, clearing the crystals the wrong place in the inner ear, usually you could do that pretty successfully with some really well-studied maneuvers. So let's do that. That's an easy win, and the patient will think you're a miracle worker usually. So it's great.
No better way to be a hero really quickly than to fix BBBV.
Amen to that. And we have some excellent journal clubs on PPV. If you want to dig into that, you can find them on our YouTube as well. But we have to consider psychological conditions. And that's because there are definitely people whose dizziness they'll even tell me flat out. They're like, yep, every time I start to feel worried about such and such, and I start to get short of breath, and then I get really, I feel tightness in my chest maybe or something, and I get dizzy. And it's just when I have those feelings. And I'm like, Okay, so there's definitely a feelings piece to your dizziness, which is okay. Our body, our brain, this is all connected and for good reasons. So, using the hospital anxiety and depression scale is an option as a screening tool if you suspect that may be an element for the person's situation, and then proper referral if they need, care for that, whether that's to, a psychiatrist or at least at the primary care know first, I would say, and it's a case of a PT, that's what I usually do, and kind of go from there. And obviously, let the patient know, hey, this could be a piece of your puzzle. That's what I like to say. And maybe you don't say that the first session. It depends on what's appropriate, but just know that these tools are here. A vestibular test that can be helpful is the hyperventilation test. And this is where you have the patient seated. You should have visual fixation removed with infrared video goggles. You ask the patient to take fast and deep breaths, at least 1 per second for at least 30, ideally over a minute, 30 seconds minimum. And basically, you're looking for nystagmus with this test. You can see it in a lot of conditions. If they have central vestibular issues, you'll often see some sort of, vertical bead or something like that kick off. That's no surprise, whether it's, a history of concussion or, somebody who has a cerebellar stroke history or something. But the highest utility has been found both for patients with vestibular schwannoma, and basically if it's positive, meaning you get a nystagmus, which would be a horizontal nystagmus, typically towards the non-schwannoma side, since the schwannoma side is usually considered a damaged side, then that, certainly could be that they have a schwannoma. So if they don't have a schwannoma, it for sure should be negative. But if they do have one, it might still not come up positive. So it's only 65% sensitive. But, you could try it if you hear a history of someone with gradual hearing loss, kind of some other things that might tip you off to schwannoma. The other thing, and this is why I really bring it up, is anxiety. So they've shown, at least in one study, that if no nystagmus is provoked, but the patient says, this is it, this is my dizziness, within the first 20 seconds, that is a tip-off that there is likely an anxiety component. So a little tool in your toolbox, if you're not already doing this and you have these patients coming in, and I don't do this with every patient, but if I'm like, like their history, things are kind of making me think this could be, anxiety could be a piece of their symptoms, you could try this. So anything you want to add about any of what I just talked about before we move forward, Dr. Chung?
No, I mean, just going through the patient history and just getting their descriptions of things, it's like, if you're used to treating pain, like you can get a sense for someone's relationship with pain pretty quickly from how they're answering a lot of their questions about pain. I find the same type of thing happening with vestibular type symptoms. If you could see that the patient's relationship with their dizziness is very disproportionate to their functionality, then that's always one of the things that I kind of take into account, that this patient might have, anxiety related issues, or they're just really, really stressed out. And that's, one of the things that we could still play a role in helping this patient, but, they do want to have at least someone to help manage some of the mental health aspects of things.
Absolutely. And it's something that I've had more than one talk with patients about. Like, that you should take care of your physical body. You're going to try to eat healthy. We try to sleep well. We try to do exercise. Maybe we're not perfect at these things, but they're good goals to have. But, our brain, our emotions, all of that is still a part of us and a part of our health. And, I think, there's continual work that's being done to normalize, that mental health is a part of our health. And, isn't this kind of like, oh, I should do better. I'm like, you're trying as far as I could tell. Like, you maybe need more support. You maybe need more tools. You maybe need to, reset a little bit and kind of do the next right thing. That's one of my mottos. So, because people get overwhelmed, which is fair, because life can be pretty overwhelming. All right. So persistent postural perceptual dizziness. I do not put this in the same bucket as anxiety or depression or other mental health issues, but it can have a feel of that because this condition does not have a test that definitively would say that that's what's going on. So we did a whole journal club in August on this topic if you want to learn a lot more about it. So I'm not going to dig into it too much. It decides to say it's still part of your differential diagnosis from cervicogenic dizziness. So you can look at the kind of diagnostic criteria and just consider that someone who has, this kind of learned dizziness, as I like to call it, kind of just a kind of a sense of fairly constant dizziness or imbalance or insensitivity to visual motion a lot of times, they can also have this kind of resultant avoidance of neck movement, neck pain, and headache. So, you could say they have both if you want. As far as I'm concerned, you should definitely take care of the neck if the neck is an issue. Let's put it that way. um, and then, address some other vestibular treatment as needed to, address maybe visual motion sensitivity, to dehabituate them to that and things. So many layers to the onion. Also one of my favorite phrases. Okay. So I'm not going to get into the neurologic screen at all. If you don't know how to do one, again, please go take courses, learn how to screen your patients so you don't miss any big red flags, cranial nerve issues, stuff that would give you pause. And, if you're not a neurologist, or if you think they need imaging, whatever it is, you should refer as needed. Don't jump to cervicogenic dizziness without, doing a bit of a neuro screen. Anything you want to add on that, Dr. Chung?
Nope, I think you said it all there.
All right, let's do it. Okay, now binocular vision dysfunction comes up. This is an eye misalignment issue, and these patients can also complain of dizziness and probably secondary neck pain because they don't want to move their heads a lot either. So there is a nice screening tool out there. We did a nice journal club on this topic back in April last year, so feel free to watch that. And just know that if you use this questionnaire, which is a nice screen with the link listed there for you, you should refer to an optometrist or some sort of other kind of qualified specialist that can handle eye misalignment issues, because this patient might need certain kinds of eyeglasses. They might need, vision therapy or something else to help them, kind of get those eyes working as a better team. And we may be a part of that too as physical therapists and chiropractic care and others in the field. So it's all a team effort in my book, but I think it's, kind of know when it's past what you can do. I do not make special glasses, so I'm not going to be, addressing that myself. I'm going to refer. All right, vascular, cannot ignore that. So this is different issues, whether it's Bow-Hunter syndrome or other forms of vertebrobasilar insufficiency. This is where if we move our head a certain way, we compress some sort of artery that has some sort of anomaly to it or blockage, things like that. So we compress and then we get these symptoms, right? So dizziness can be one of them and nystagmus can be another one, but usually there's something else. Have you seen this in clinic, these different kinds of vertebrobasilar insufficiencies? What are your tip-offs there?
I have not seen any of these in clinic so far as I've been in there. So I screen for them, but nothing's ever tipped me off that this patient's having a vertebrobasilar type of an issue. So I can't speak from clinical experience. I can only say from what I've read, and it's part of my screening because I don't want to miss it. But
yeah,
for better or for worse, it hasn't crossed my path.
Yes, me either, and I'm glad to say it. But I've known clinicians who have, and the hope is that a lot of these would get caught by a physician, but not necessarily, right? So we may be the first one. So it still might come in our career. We're not done yet, Dr. Chung. So you never know.
For sure.
You could get one tomorrow. So the key here is, I think really think about the symptoms. So are they getting double vision? Are they getting slurred speech? Are they getting difficulty swallowing all of a sudden? Are they almost passing out? These are not what you're going to see if it's cervicogenic dizziness. This is not what you would expect to see in somebody who has BPPV. So we're really going to try to think about, these kind of sudden or even gradual over a few seconds to a minute onset symptoms when we were kind of maintaining a certain neck position. Right, so that should kind of make us think about vertebrobasilar insufficiency. And the vertebral artery test, I did put it up here. Unfortunately, if you do that test and it's negative, it's basically no guarantee that they don't have it. So there are some recommendations about stroke risk factors if they have at least 3, and if they have this kind of history of an isolated positional vertigo. Well, when my neck is this way when I was trying to paint the ceiling or whatever. people do when they stay in those positions for a period of time. It's kind of unexplained. And especially, of course, if they report even if you don't see it in clinic, yeah, and then my wife said my face was kind of droopy and she couldn't understand what I was saying. Like, these are tip-offs, right? So, keep that in your mind and don't mix that up with cervicogenic dizziness. All right, now I felt like I had to put this up because we're going to talk a lot about manual therapy in a minute. So my big question to you, Dr. Chung, is on this list of kind of absolute contraindications, and there's also some precautions here as well, to doing manual therapy, was bone disease. Does that include osteoporosis? Give me the skinny on this.
So if you're going to do like a high velocity, low amplitude type force, then it would probably include osteoporosis. But there's so many elements of manual therapy, so many types of manual therapy that don't involve the HVLA type of approach that I think many manual therapies can be done safely, even in the presence of osteoporosis, osteopenia. Like I see quite a few patients with pretty severe osteoporosis, but because my chiropractic approach is exceedingly gentle, like it's not
Mm-hmm.
really a worry from my perspective. But certainly, like some of the high velocity type maneuvers, then it's one of those things that's in the gray area where you probably want to lean away from it.
Absolutely. And then I just want to I don't want to spend all day on kind of joint laxity issues, Ehlers-Danlos, that kind of thing. But when you have those patients, you can still do manual therapy, in my opinion, on them. But what kind of considerations do you think about with that group?
So one of the things that we do in the chiropractic aspect of things was we'll actually take stress x-rays on some of these patients. So we'll do a flexion extension type of x-ray. If we see that there's an exceeding amount of instability on there, then that's kind of a no-go
Okay.
for us, especially if it's happening and like you see that increased ADI space on an x-ray. It's like, all right, well, this is kind of out of my hands now. So
Okay.
that's definitely one of those situations. If it's not in that realm, like, again, I'll see many EDS patients, but it's one of those situations where some of the HVLA stuff, you probably don't want to go too deep into that, but some of the more like slow, like
Mm,
gentler types of manual therapy, I think is something where it can be used judiciously because in the end, I think a lot of these patients would probably benefit more from strengthening in
mm-hmm.
those types of scenarios anyway.
For sure. And I think that's where it's, take the big picture. That group tends to be, they have too much mobility, right? So it doesn't mean all
Correct.
manual therapy is not bad, but when they'll be like, oh, I'm tight, I'm like, I know it sounds counterintuitive, but you need to strengthen because things are trying to
Yeah.
hold you up. And that's why maybe certain things are getting or feeling a bit tight. But really, it's because you're bobblehead and you need to, get certain muscles up to par, right? And then we talk about that. And yeah, I'm on the same page as you for that, too. So, all right, good. I just want to have my own curiosities. Hopefully, other people wondering those things, too. All right.
Mhm.
So we're trying to diagnose cervicogenic dizziness. Lots of tools we can have in our toolbox. We're not going to talk about all of these at length. This is a list for you all to explore, and we're going to talk about course options and other ways to learn at the end. So don't worry, lots of options to grow your knowledge about these kind of exam techniques. We really need to get to the treatment piece shortly. So the only ones I really wanted to talk about that I think you'll have something to say about because you have some nice YouTube videos out there on some of these
Mhm.
are some of these kind of repositioning or kind of head neck type tests. So one is the cervical neck torsion test. So just want to talk us through, do you use this? Is it helpful? What do you got?
I do use this test. It's not one of my go-to ones. So I was one of the tests that I will incorporate if I'm already doing like a smooth pursuit neck torsion test. I personally love doing neck torsion while doing a posturography type of exam on them. So that one I tend to find is like pretty darn good at identifying cervicogenic types of dizziness. But this is something that I will throw into the mix. It's just not one of the ones I go immediately to because I'm doing some of the other ones.
Got it. Perfect. Yeah. So y'all can hopefully read what's on the slide here. Essentially, you're having the patient seated. They turn their head. See if we're reproducing that symptom that they're kind of coming in with, this complaint of dizziness, off feeling, whatever. And then we hold their head still, and then we turn the body. So in theory, you're not really stimulating the vestibular system at that point. And so what's kind of being activated would be the neck and the neck proprioceptive sensors. And if that's when it reproduces their dizziness, it's either going to reproduce dizziness in both, or only when the head was turned, but not when the body was turned. And if it's just when the body was turned, when it's just when the head was turned, then that would make us think vestibular. Have I got all that right?
So yeah, if the head is turned, then it could still be both,
Yeah.
vestibular or neck torsion. But if you're isolating just the neck torsion, then it makes it much more likely that it's neck, and because the vestibular system is not getting the level of activation.
Perfect. All right. Good summary. All right. Then a family favorite. It's not the only test you should do. I just want to emphasize that. I feel like some people are like, oh, I did this one test. They definitely have cervicogenic dizziness. I'm like, but it's a great one. You put the laser on the head. Just love those lasers. And you have to be a certain distance, 90 centimeters from the center, kind of rotation of the head is the way it's written in the literature, from the wall where you're going to be putting the target. You ask the patient to get the laser that's on their head centered and eye level. Then you put up your target to match that. Then you have them close their eyes. You ask them to move their head in a direction, right, left, up, or down, whatever you want to start testing first. Tell them, the way I have been taught to instructed is move your head, kind of as far as you feel you can comfortably to the right, let's say. And then while the eyes are still closed, move your head back to where you feel like it's where you started. And then what would be abnormal, if you see that picture there, is on the red circle or on the white part of the paper or the wall that's past the paper, whereas anything in the green or yellow portions is considered within normal limits. So you're supposed to do multiple repetitions, because a lot of times the first couple people are pretty off just because they're like figuring out what the test is. And getting a sense of it, and that's a learning curve. It's normal, but after that, we should start to see real consistent, kind of landing in that green or yellow. And if we're not, we tend to see them land consistently off, like to the right lower corner or something. So they start to kind of have this consistent pattern. Is that kind of what you've seen as well, Dr. Chung?
Yeah, that's definitely been my experience. And usually if I'm suspecting cervicogenic issues, then they will sometimes just be out of the circle completely in some of these cases too. So that's, my market for thing, because, I know that there's standardized measurements for it, but just qualitatively, I'm just looking to see, like, are they within range of being in the center, and with repetition and practice, are they getting better, or are they still just not any good at it? So that practice effect, if we're not seeing it, then that makes me highly suspicious that that vestibular proprioceptive input is not effective.
Absolutely. No, it's a great tool for sure. And it's a nice one as a PT, I can write goals about it. So if I'm seeing it being really off, I'd like to see it get more normalized. So I'll write a goal about that. With that, once you know how to do that test, you can definitely do this test. This is the trunk head test. So they have a laser on their chest at the center as well as on their head. And this is kind of in the spirit of the test where we had the patient turn their head and then turn their body. This patient is now going to be tested doing the standard joint position error test we just talked about on the last slide. And then you have them turn their trunk 45 degrees to one side, and they perform that same test again. And then on the other side, same test again. And if they are much, much worse, whatever that's supposed to mean, there's definitely more deviation from center when the trunk was rotated. Again, considering that cervicogenic dizziness. Have you tried this version at all? I just learned about this recently myself.
I played around with it in courses, but I haven't done it on any patients, to be honest. It just seems like the setup for it is harder to be consistent with like lining up that chest strap. So like I just never felt confident about my ability to do that.
Fair enough. Yeah, no, same. I've used it very rarely for that same reason, to be honest. But I think the concept is good, and in the spirit of being thorough, I want to make sure we talked about it because we're looking for anything that can help, kind of be giving us more information on this kind of elusive diagnosis. All right, so this is an old favorite, I hope, for anyone who's done manual therapy, whether they're chiropractic PT or a variety of other excellent disciplines as well. You're basically seeing if the patient's upper cervical spine has significant limitations. I've got it written out in here. I'm not going to read it out to y'all. And I've got the norms here kind of underneath the photograph. But basically, you're putting them into this kind of full flexion and measuring rotation there. And if that's much more limited, then it should be, as you see, written there, then we know that the upper cervical spine is having issue. Let's put it that way. And something that may need to be addressed and could be contributing to dizziness. By itself, it would not be a diagnostic for cervicogenic dizziness, but, lets us know if the neck is having issue. And then the side bend rotation test kind of puts side bending into the game, looking at kind of C1, C2 versus C2, C3. Again, I'm not going to read this out. Learn more on your own, go to courses, but it definitely should be in your toolbox. Anything you want to add on either of those, Dr. Chung?
I love the max flexion rotation test as a pre and post for how a patient's response to manual therapy is, because if I'm working on them and I've adjusted their neck and I'll redo that test at some point, and they notice that like their neck can move farther, and more importantly, it doesn't hurt them when I'm moving their neck. Like that's usually a big win.
Yeah, totally. Love it. All right, finally, we're getting to the study. All right, so I hope everyone can forgive me, but cervicogenic dizziness cannot be discussed without covering, I feel like, all the stuff we just covered. So thank you for staying with me. We're going to talk about the manual therapy piece here. So in this study, they tried to compare these SNAGs, which I've already said it, and I'm not going to say them again, what that stands for, versus the Maitland mobilizations, and then a placebo of a deactivated laser that appeared to operate normally, but had a light flashing and a beeping sound for 2 minutes times 3 sites on the neck, which is a fun little placebo idea. So they included patients with a history of imbalance and neck pain, stiffness, or both, and a history of neck movement or positions provoking dizziness. They had a wide age group, dizziness for more than 3 months, upper cervical spine dysfunction to palpation, and cervical range of motion impairments, negative testing for smooth visual pursuits, which is kind of like a quick visual screen for central vestibular issues, I would argue, vestibular reflex, blood pressure, and Dix-Hallpike. They're trying to kind of rule out the big ones. It didn't seem as thorough as it could be, but, I didn't do the study. It's cool. And then they did do vestibular peripheral function test in otoneurologic office. They did not do any of those tests we just named that I'm aware of, if I read the article properly. So that could be an area of why do you think that was?
Yeah, that one I'm not sure, because certainly those tests have been around, but it seemed like they just wanted to like cervicogenic dizziness has been like a diagnosis of exclusion, so it's just like, all right, we've excluded the big players, the most common players, so now we're just gonna assume that it's cervicogenic based on that.
Yeah, so I know the Baronet Society would have maybe an issue with that because, what we already read about with their position statement, but that's okay. We're going to go on with the study and just note that that's a limitation. It doesn't make it, I think the study still has good input, but just I think it's good to note that that was a limitation. They did exclude patients with what they could identify as other types or causes of dizziness, which is good. So we don't have people with multiple conditions kind of concurrent that would maybe mix things. They did exclude people with other causes of poor balance, kind of neurologic conditions, that kind of thing. Anything that contraindicated manual therapy and other various situations. So let's get to the treatment. So we got the Mulligan snag treatments. And this is where you're positioning, your thumbs in a certain position. You're applying this kind of sustained gliding movement. Any thoughts on the way that this was applied?
I didn't have any big thoughts on it. I mean, when I was going through there, it's just like, I mean, it seems pretty standard. Whenever I do a snag on someone, like I usually just do it bilateral anyway. So I'll go right side and left side. I don't like I know when a patient has symptoms or feels uncomfortable to one side versus the other, but usually I'm just going to mobilize both sides when I'm going through treatment with someone.
Okay, great. All right. They did add a second snag when clinically justified. They kind of add a little gentle overpressure in subsequent treatments, and then they gave a self snag for homework. Um, they showed a picture of an example working into extension there with a strap. Do you give homework as far as snags?
I do. I'll have a patient learn how to do it with like a towel,
Mm-hmm.
and I'll give them homework on that, and I'll try to make sure that they could do it effectively on using the towel. If I see that they just don't have like the motor coordination to do it, then I just have them use their hands and just apply pressure with their hands in kind of a similar fashion to
Mm-hmm.
try to recreate some of the motion.
Got it. Yeah, you do what you can for sure. I'm with you.
Yep.
All right. So there are other versions of snags. There's what I've read is called the headache snag, which is kind of more of a retracting the head against the towel or strap. There's the rotation type snags, which they did describe in the article a little bit. Are these ones that you also give as needed?
Yeah.
Awesome.
Yeah.
All right.
Fortunately, like I don't have need patients to do these terribly often while in during my treatment, but it's one of the things when patients always ask, what can I do at home? Then these are one of the things that was prescribed for them.
Perfect. All right. Now, then they tried the Maitland passive joint mobilizations. Again, they were, kind of focusing on what they felt were the impaired joints or jointer joints. There's a grading system, which is on a separate slide that we'll get to. 30-second applications at each spinal level treated. And then they also gave a bit of homework with range of motion, flexion, extension, rotation, lateral flexion 3 times in each direction, once a day. Do you use Maitland passive joint mobilizations in your practice as well?
I don't. I've read about them, so I have some vague familiarity with them from a reading standpoint, but I've never seen them used. I've never learned them, so it's not something I have terrible familiarity with, at least in a live setting.
Fair enough. All right. So here's are the grades. I promised you'd see them. Here they are. There's everything from 1, which is a small amplitude, out of resistance, all the way to that grade 5, which is essentially is HVLA, high velocity thrust. They did find that both manual therapy groups reduced dizziness intensity as rated on a visual analog scale and frequency post-treatment and at 12 weeks, and less dizziness compared to the placebo group at 12 weeks. Both manual therapy groups had less dizziness post-treatment, less dizziness intensity, excuse me. And they also did not have a change on their dizziness handicap inventory or their pain. Oh, sorry. They all had a change, even the placebo. That's what I
Yeah.
want to say. So
Yep.
there was no
Yeah.
difference,
Yeah.
which to me makes it like a little question mark, right?
Yeah. That
um,
was a little bit unusual. That's
yeah, and I would think neck
um.
pain. That was a surprise to me, I have to say. Um,
Yeah. But seeing someone's like VAS type dizziness improve, but not improve in the placebo, but their DHI scores improve was something I was like, huh. I don't think I've seen that type of phenomenon before.
yeah, I mean, it is what it is. We just read the study and think about it. But anyway, and they felt that there was a effect in both cases with the manual therapy. I think what's tricky is the placebo, although it was better than no placebo or, group, which unfortunately you often see with studies, which is very frustrating, is hands-on the same as a laser light situation with beeps? I would argue no. That personal touch is key. I'm not saying that this is a bad study. I'm just saying I think that, again, that's a limitation. I would love to see something, a little more kind of truly comparative. I mean, the good news is these patients, got better, of course. So the study provides evidence that 2 to 6 sessions of intervention and some home exercise could help cervicogenic dizziness. It is important to acknowledge that this clinical trial focused only on one aspect of management of cervicogenic dizziness, which we're going to get into why probably manual therapy by itself is not like the answer to all cervicogenic dizziness if you think that's what the patient has. And you'll see here on the right that there's strengthening you can do, there's, kind of postural work you can do, and you can not only test neck proprioception, but you can train it. So there's lots of other things that I think should be important elements if this is something that you really want to kind of fully treat. So we do want to treat the neck, and I put a lot of information in here because I think even though this study only looked at snags and the Maitland passive joint mobiles, there's other manual therapy that could be done. So, for example, I'd love for you to speak on thoracic mobility for a sec.
Sure. So a lot of patients with just cervical spine dysfunction also have really limited thoracic spine movement as well. And I find that a lot of patients can have like referred pain patterns between that cervical thoracic junction. And there's been like studies even on cervicogenic headache where like the combination of doing a high velocity, low amplitude um, mobilization into the neck and the upper thoracic spine like helps with cervicogenic headache too. So I think there's room for assessing thoracic spine and using that as a way to help improve just global spine mobility.
Mm-hmm.
Because I think if any part of the spine is having some issues with fixation, then there's probably going to be a decreased proprioceptive effect in the brain as a whole. And even though the cervical spine is like the highest density of proprioception, like you still want mobility throughout the rest of your joints because, a normal functioning human body has that mobility and the brain is comparing what normal felt like versus the current state that it's in. So assessing that thoracic mobility, I think, is important, and using not only just like thoracic spine adjustments or thoracic spine mobilizations, but there's so many like good ways that you can mobilize the thoracic spine with movement and exercise that are really beneficial too.
Absolutely. And I think, when I was in school, I was taught to work up and down the chains. The person has a knee problem, you better look at the ankle and the hip at a minimum, possibly all the way up to the neck, because something that's going on with one area can cause them to lean to one side maybe, and now they're, kind of asymmetrical loading on a hip, and now that hip's getting pain or whatever. So you have to really think, okay, even if the dizziness is coming from a neck that's impaired, maybe I help the neck, but if I never touch the thoracic spine and that was leading to the neck problem, then you know what I mean? Like you're going to end up getting the same problem again potentially. So it is good to kind of look up and down the chain. So I'm with you.
Yeah, look at the shoulders too, because you have those connections between the traps and the levator scapula that connect the cervical spine and the shoulder blade as well. So a lot of people like will get referred pain through that shoulder blade area, and helping the shoulder have good mobility is probably helpful too, in my opinion.
Amen. I'm with you. It's all connected. Some kind of Flintstone song about that. All right. So vestibular rehab, I didn't want to ignore it. It should be a piece of the vestibular or the rehabilitation puzzle for people with cervicogenic dizziness, if that's what you think you have going on. So I say treat neck first because a lot of vestibular rehab stuff wants you to move the neck. So if the neck is really cranky, it's going to be hard to successfully do like this, or even look to a target, turn your head, look to a target, turn your head. So I like, to kind of start at the neck, maybe really light vestibular work at first, and then, as the neck and thoracic spine or whatever else is going better, feeling better, then we can be, more exciting about our vestibular rehab activities. And then, of course, last but not least, training that joint position sense. There's so many ways to do this. You can do it lying down on your side, hands and knees, on your elbows, in a plank if you're really feeling strong. Whatever's appropriate for the patient, you got to kind of meet them where they are. One of my other favorite phrases. Obviously, you can do it seated, standing, with a balance challenge, walking. And that's just movement stuff. Then you've got the different types of targets, the different tasks. You can make it dual tasking with a cognitive component. You have to spell all the months of the year backwards if you want to be really mean, whatever. So there's like so many options and lots of great tools out there. A little shout out to Motion Guidance and other different companies that have options, so we can get good lasers, we can get good targets, things like that. You can get really low if you don't have any budget. Baseball cap, attach a little, laser pointer with a alligator clip. Do what you got to do. And now I want to talk about a little more. I promised everyone on my social media that we would talk about some other stuff that some people have used to try to treat cervicogenic dizziness. I want to say that there's literally like maybe one or two or at most three articles touching on each of these options. So it's very limited information, and some of them like case studies, which is like one person or a couple people. It's not really strong. We need more research. That's what Baroness Society said. Agreed. So distraction. This is the kind of gentle pulling away, if you will, opening up, lengthening, trying to make them taller, Gumby, whatever you want to call it. Do you use cervical distraction?
Very rarely. It's definitely not one of the things most commonly used in my toolbox. Like literally, I might do a little bit of it when a patient's having like radiculopathy symptoms, and just that distraction kind of reduces their experience of radiculopathy for the moment. Like I'll deal with those patients, but certainly not one of the things I go to with cervicogenic dizziness.
Fair enough. All right. How about dry needling? I've never done it. I know what it is. I don't know if it's in your toolbox. I'm sure you have some familiarity with it.
Some familiarity, but I don't use it. I refer to some PTs and chiros locally that will do it. My recommendation for getting is like if someone has some really bad trigger points or something like that, then say, hey, maybe dry needling is something that could be useful for you. Here's some practitioner that does it. I don't currently do it, but I know it can be helpful for some patients, especially with pain issues. And since you still have these pretty bad trigger points in your neck, it could be valuable for you in that scenario.
Perfect. All right. I know you're friends with high velocity, low amplitude, or HVLA thrust. The article that I pulled a photo of it where they were doing this treatment with, actually looked like some combination of distraction and then a thrust motion. They have some hand placement on some spines to try to tell you what they're doing. I have to be honest, I didn't really understand it. That is not my comfort zone. If I think people need that, I am referring. So what do you want to say about that?
I think there's some value to it, even though I don't really do it in my clinic. I have lots of colleagues that use it as part of their treatment plan, and they, report that patients with dizziness, like they'll see them and they'll get pretty decent outcomes with it. But again, it's just not one of the things that I'm doing with a lot of regularity. But I think there's some patients if it's not contraindicated, and there are some patients that just really like that style of adjustment
Hmm.
and mobilization. So those might be those patients that get a good result because they're already wanting that therapy anyway. And it just gives them that peace of mind that makes them they feel like they got something that their brain needed.
Yeah.
I know in the chiropractic neurology world, like Dr. Carrick teaches like a brain-based adjusting where he teaches how to use levers and the manipulation or adjustment process that affects the brain in specific ways. So certainly from Dr. Carrick's experience and some of the other functional neurologists out there, I know that they find it to be valuable in a case by case basis.
Sure. Absolutely. Soft tissue, can't ignore the old massage. So, again, not a ton of research. I did find an article that was comparing what they called cervical mobilization with traditional massage, but they had a very specific protocol, and you see it pictured here on the right for the cervical manipulations. So, they are rolling the muscle in this direction, and then they're, rubbing the earlobe. I mean, I'm not saying this isn't like a valuable method, but it's something that I was definitely unfamiliar with, and it seemed to be very specific. I recommend that you read the article if you're curious and you want to learn more about what they were doing. They did 6 20-minute sessions over 2 weeks, with either kind of this more like specific mobilization versus what they call traditional massage, where they were again really very much soft tissue, I would say, based on what I could, kind of interpret from the descriptions. It's so much better if you'd have a video and I could have like seen what they were doing. But it's one of the limitations of articles is you've got these like kind of not great photos usually, and then these like verbal
Mhm.
descriptions that you're trying to sort out. But that's okay. They felt like both groups did equally well based on the DHI, which is what they used as their kind of primary outcome measure in terms of reducing dizziness. So, there's people out there trying different stuff. Unfortunately, we don't have a ton of research. So that leaves us to this slide, which is basically what I've said a couple times now. Further research is definitely required to answer whether there is such a thing as cervicogenic dizziness as we understand it, and then what treatments would be best, including specifically which of the manual treatments might be best. And the answer I know is probably going to be like, it depends. Like, did the person have upper cervical limitation? They probably do need some movement there. Does they really have a ton of guarding in their soft tissue? They probably do need some work there. Anything you want to add on that, Dr. Chung?
So I think one of the things that like it's easy to get like lost in the like vastness of all these different manual approaches. But at the end of the day, like we're hitting the proprioceptive system, and a lot of what we're trying to do when we're stimulating some of these systems, we're trying to stimulate the systems in such a way that makes the brain feel safe about its environment. So whether that means like a patient gets a snag or a patient gets a specific type of adjustment, like in my office we do these really gentle upper cervical adjustments, or if they want that HVLA adjustment, like each of them are going after the same system, but it's about which one is making the system feel safe, right? And which one is going to calm down your autonomic nervous system in that way and turn down those sympathetics. And that, has some benefits in itself and just making you feel better, even if it's not addressing the specific pathology at play. So I think it's important that we like anytime that you put your hands on the patient, you're probably affecting the proprioceptive system in some way, and the method that you go about doing it probably matters less than the fact that you're actually getting the spine to start to move better. And as long as the spine is starting to move better, then there's probably going to be a net benefit if the patient actually has cervicogenic dizziness.
Yes, I love all of that. So, this slide gives us some nice background on Dr. Chung and the name of the course that he has up right now on Carrick Institute, which is called Neurology Essentials for the Upper Cervical Chiropractor. And I did find you, and I'm guessing that if you live in Detroit, you could use this kind of find a provider for the National Upper Cervical Chiropractic Association to help if you need to find someone to whom you would refer patients for this kind of care, or if you wanted to learn more. Also, feel free, if you want to learn more, to follow Dr. Chung on Twitter and Instagram. I have got those handles there, and his awesome YouTube site with lots of really great videos, because he understands that learning through videos is really great. And it's always good to have, show me how you did it. So that's there. I recommend you checking that out. And then there's other cervicogenic dizziness resources out there. I pulled a few that are my favorites: cervicaldizziness.com, or their handle there on Instagram at cervical_dizziness. That's kind of an ortho vestibular team, a married couple that have got books and a 16-hour self-paced course and some free resources. So I do recommend checking out their what they have to offer. And then they're just put out, I just saw it advertised right before this journal club, a 2-hour online course by Dr. Trelevian, who we mentioned. She's done a lot of the research on Australia. She's from the UK, I believe, but she's through this Physio Network is an Australian company that does continuing education courses. So they have a free 7-day trial, or you can pay a little bit per month, and you could take her 2-hour course on cervicogenic dizziness if you just want to dip your toes in before you go to the 16-hour course or something like that. Or, of course, Dr. Chung's course as well. And then if for some reason you want to find a PT, there are ways to do that as well. So I listed that link for Find a PT. We are going to go to questions. All right. So the first question that I had, because I always write my own questions because I have a lot of curiosities. Actually, this isn't from me. I'll be honest. This is Heather Campbell, who's a lovely physical therapist out in Colorado. I do have a couple of my own too, but I'm going to ask hers first just for time purposes. So she said cervicogenic dizziness might be better divided into cervical proprioception, cervical autonomic dysfunction, and cervical vascular considerations. How would you respond to that?
I think that's probably accurate. It's just a matter of, like, besides the vascular aspect, does it matter as much if you're kind of treating the same area, in my opinion? Because no matter if a patient has cervicogenic dizziness or if they have cervical autonomic type issues, my treatment of them doesn't necessarily change drastically. Like, I might change some of the positions I might do the exercises in
Mm-hmm.
if they have an autonomic issue. But for the most part, my approach isn't terribly different. Like, I will screen someone if they have any autonomic issues, like using some of the orthostatic testing. I'll look at someone's heart rate variability, and those kind of give me a sense of like what that person's autonomic state is. But at the end of the day, it doesn't necessarily tell me if their autonomic state is a result of their cervical spine dysfunction or not. The vascular thing is just something that it's always on my radar because there's just lots of people that have high vascular risk factors, especially right now where like, we're seeing a lot of patients that like are having strokes when they're younger. So whether someone has a cervicogenic dizziness that I'm worried about a stroke, like I'm screening them anyway because I just want to know that the person's safe to work with and they don't have an emergent issue at hand. So I'm always checking cranial nerves.
Mm-hmm.
Um, I'm doing HINTS exams on people, so I'm looking at head impulse tests. I'm checking to see if it's correlating with anything with the cover on cover. I'm looking at the pattern of the nystagmus, which is why like having goggles is such an important thing. Is like you could really see the pattern of nystagmus. So I think all of that is important to just screen anyone with some type of cervical or cranial type of an issue because we just want to be vigilant about that now and not miss these things.
110%. So she put in a second question that I will ask as well. The study reported excluding individuals with psychogenic dizziness, but none of the assessments, because I had listed those out, cited related to psychological function. My guess was that they just maybe asked the patient, or maybe just kind of if the person indicated, my doctor says this is anxiety related or something, that they automatically did not include those patients or individuals. What are your thoughts on that?
My guess is they might have just screened them and asked if they have a history of anxiety or depressive
Mm,
disorders. And if that comes up on just like a health intake, then maybe that's part of the exclusion criteria. If I were to guess, I don't know if that for sure because I didn't
yeah,
look that deeply into it, but
yeah,
um, that would be probably the most painless way to do it if you're not actually doing any questionnaire.
right. It's not a great way, I suppose. I'll agree with Heather if that's the implication that she might be making there, as it would be nice to have something a little more objective. But I understand running a study can be pretty challenging. So um,
Yeah.
I'm sure they tried their best for no doubt about that. Um,
Hey, Alina, my camera's going to be offline for just a second. I'll be still on so I can hear everything. Okay.
yeah, that's fine. No worries. We just have one last question, and then we're going to kind of wrap this up because we're a little over time. Um, what do you think of studies on coblation discopathy and other surgeries that have been done as a treatment for cervicogenic dizziness? There is research on that.
So that's something that, I've read the literature on it, and that's something that I've always found really interesting because some of the uh, the pathologic mechanisms for it were really, they had some interesting findings with that. The fact that like they identified that there were increased proprioceptors inside of some of these disease discs was something that was interesting to me because in my head I would have thought that it was decreased and that there was some type of deafferentation type situation, but it was actually the opposite of what my
Right.
expectations were. So, and additionally, like we know that cervical disc issues most frequently affect people down in the lower cervical spine, and the fact that someone can get good outcomes by cutting lower cervical discs and affecting their cervicogenic dizziness was something that was super interesting to me. I didn't necessarily have a great way to make a whole lot of sense from that based on
Right.
um, what my physiologic understanding of cervicogenic is, dizziness being like a mechanism primarily from C1 to C3. So I thought it was very interesting. Obviously there's some of the drawbacks, so like it's not like in a randomized type of a fashion, so it's hard to like, you know, delineate the cause and effect aspect of it because, maybe they felt better because they had a surgical procedure done, and maybe they felt better just because, they took away some of the pain aspects and how pain affects your autonomic nervous system. It
Right.
makes you have this feeling of being unwell that's not necessarily like, a dizziness type thing, but it's just like an autonomic type issue where the pain is like really making your anxiety and all these things like just run out of control and you just don't feel good. So I
Right.
think there's, still stuff to unpack there because like it doesn't necessarily match up with like our biological understanding of this, right?
Definitely. And there's just a smattering of articles that don't talk about cervicogenic dizziness, but talk about patients with dizziness after neck surgery. So it's kind of interesting too how I feel like it can go either way almost like, oh,
Yeah.
we did this neck surgery and now your dizziness is gone that you had, or oh, you didn't have dizziness, but you had neck pain and, whatever, they did surgery to address that. And now there's post-operative dizziness that they think is from the neck. So it's definitely tricky business.
Yeah. And until like you kind of like randomize some of this stuff, like it makes it even harder to like get that cause and effect relationship too. So yeah, I found the research interesting. I don't really know how to make a whole lot of sense of it.
For sure. So more will be revealed. Look forward to more articles for sure. And in the meantime, I appreciate your taking the time for this discussion on what is definitely, I would say, a challenging topic. I think you did excellent with it. So appreciate your insights and input. And thank you everyone else for tuning in. We look forward to seeing you next month. We are having Dr. David Z talk about eye movement disorders and the cerebellum, which should be super fantastic. I know you'll be watching that
Ooh,
one. I know,
yeah,
right?
that's a good one.
If you don't know, Dr. Z like literally wrote the book on eye movement disorder and the cerebellum and so forth. So it'll be awesome. So see you then. Until then, have a wonderful night and a wonderful month. And thank you so much, everyone.